Welcome to Westmead Private Hospital's virtual GP education program. Today we are joined by cardiologists Dr. David Tanos and Dr. Gopal Sivayangabalan. Today, David and Gopal will be discussing cardiac causes of stroke and leadless pacing.
Hi everybody. So I'm going to talk about cardiac causes of stroke and also the management or the cardiac management of stroke. And I come from a background where I get a lot of referrals for closing PFOs, which are a cause of stroke, but I work closely with neurologists, and I think that's important because I think not all presentations that seem like stroke end up being stroke. And as you go through this presentation, I'm presenting a real life case where we'll just look at the different aspects of different causes of stroke. So this is a woman I saw in May. She was 63. She presented with a left involuntary movements. She developed left-sided hemi-neglect and an expressive dysphasia. Her background is important in that she had a ANCA positive glomerulonephritis, but renal function was reasonable. She had hypertension and hypercholesterolemia and intermittent palpitations over the years when you pushed her on it. Her MRI showed a small right-sided MCA stroke involving the parietal lobe cortex. So first, I guess, question one, which you can use the little poll for, which of the following is not true? A, the likely cause of stroke relates to hypertension and therefore no further investigation of stroke is necessary. A cardioembolic stroke is possible as it's a cortical stroke, and treatment with an ACE inhibitor and a statin will reduce the risk of recurrent stroke. And D, early anticoagulation is not recommended. So if you want to try and get your answers down.
Yep, sorry, I just, I think, oh no.
Here it comes.
Questions coming through, good. I thought I just messed that up then.
So it's a tricky question. So which of the following is not true?
So just while we're waiting for that poll to come through, there's a couple of GPs that said that they can't hear you.
Okay.
I can hear you plain as well. It's all going well from mine. So if there's anybody else that can't hear, can you please pop a message through the chat? But you'll just need to check your audio from your end because everything's working from our end and most GPs are hearing it. So I'll hand over to you now, David, to go through the results of that poll.
Yeah, so I guess close to the majority have said A, the likely cause of stroke relates to hypertension. So it's a negative question, and that's the right answer. And it's a tricky one, and I'll go through some of the aspects of her stroke. So I might take that down. We'll just close that so it's not on my screen. So when we look at strokes, you can think of cortical infarcts, like ones that are around the cortex, and they're generally due to the occlusion of a cerebral artery, and often from either an embolus from the heart, the aorta, or the carotid artery. Whereas lacunar infarcts are these small ones, which can still be devastating if they're in a critical area, and they often are related to hypertension and diabetes. So if we get back to our question, what I was getting at was hers was a cortical infarct as opposed to a lacunar infarct, and hence it probably wasn't so much related to hypertension, even though hypertension will be a major aspect of her management. I'm not going to bore you with these, but when we look at the cardiac embolic sources of stroke, there's a number of things, and the big ones are atrial fibrillation, a left atrial thrombus, a mechanical valve. There's other things like if they've had endocarditis or a previous infarct with aneurysm. And there's other ones that are less likely to less likely to be a cause. I won't spend too long on that because I want to focus on the major causes of cardiac stroke today. So when you look at someone with a stroke, I guess I got to emphasize this. While the majority of work I do with people with stroke are closing PFOs or other things that are really, or managing the atrial fibrillation, at the end of the day, the things that are going to make a major difference are the management of the major cardiovascular risk factors, similar to management of coronary artery disease. So going through each of these, in terms of lifestyle factors, while these are not so much secondary prevention, in primary prevention studies, smoking doubles to 4 times your risk of stroke. So similarly, if you had a previous stroke, cutting back should reduce your risk of stroke. Focusing on weight loss, reduced sodium, regular physical exercise. In primary prevention studies, obesity almost doubles your risk of stroke. And alcohol is a bit tricky in that while it does reduce, may have a slight reduction in some cardiovascular outcomes, it does increase others. So the recommendation is just to limit it to 1 to 2 standard drinks a day. And I guess along with this, adherence to pharmacotherapy. So if someone's been, I guess I'm putting that under lifestyle. So if someone's been prescribed a aspirin, a statin, and an ACE inhibitor, not taking them is, well, that's not really helping them. In terms of blood pressure lowering therapy, if someone presents acutely with a stroke, you tend not to lower the blood pressure in the first 24 hours unless the blood pressure is sky high. And I guess this is something you won't face in the general practice, and I won't face as a cardiologist. But once that first 1 or 2 days has passed, ideally you'd like to target a blood pressure less than 140 on 90. Being too aggressive with blood pressure can actually worsen some of the symptoms of stroke. And I think sometimes you see it where someone's had a previous stroke, they get tired, they get hypotensive, and they say, oh, I thought I was having a stroke again. My arm was getting weak. Now, which agents should you use? Look, I think some of the big studies have been with ACE inhibitors, but basically any antihypertensive works, and any combination, except beta blockers should not be used as first line in the absence of other indications for them, because there has been a study showing an increased risk of stroke. So there's consistent benefits where treating hypertension reduces your future risk of stroke by about 25 to 30%. Interestingly, lipid lowering leads to a reduction of recurrent stroke. So I think for every 1,000 patients treated, you're getting 20 fewer ischemic strokes, but you're getting 8 more intracerebral hemorrhages. So they're not indicated in people where they've had a cerebral bleed. In people where there's a non-ischemic cause of stroke, meaning like an embolic cause, you don't feel so strongly about using them. High-dose statins are recommended basically because the studies used high-dose statins. And there was no significant benefit with using fibrates. And there was, in fact, an increased risk of stroke with fibrates. What antiplatelet agent should you use? Aspirin with diapyrimidol. Aspirin and clopidogrel for the first 3 weeks, but after that, if you use it in combination, there's an increased risk of bleeding without any added benefit over aspirin, clopidogrel alone, or aspirin and diapyrimidol in isolation. There's probably a slight advantage for clopidogrel over aspirin. So really what I'm trying to, I guess the crux of this is, if you aren't going to do anything else, treating the modifiable risk factors and lifestyle factors will do a lot for reducing someone's future risk of stroke. Now, 2 important mechanisms of ischemic stroke, which are important to assess for, which are clearly reversible, are the presence of atrial fibrillation and carotid artery stenosis. And in terms of atrial fibrillation, a DOACs, dabigatran, rivaroxaban, sorry if I haven't said apixaban have a benefit over warfarin that's marginal and less bleeding risk. So basically, how much AF is enough to cause stroke? That's a big question. I reckon Gopal will know more about that than me. But the funny thing is, you can do a Holter monitor and you'll sometimes get a report saying 1 minute of AF, 10 seconds of AF. That's often not AF, it's often atrial tachycardia. So you've got to be a little cautious about interpreting those results. So, so basically, I think in someone who has been found to have AF, it's a clear decision that starting anticoagulation is important. In hospital, if someone's had a very large stroke, you tend not to start the anticoagulation too quickly because of the risk of hemorrhagic transformation. But basically, by about 2 weeks, most people who've had AF would have started on an anticoagulant.
David,
Okay.
just to add,
Yeah.
the recommendation is that if there's more than 4 hours of atrial fibrillation in a month, so if someone has a single prolonged episode, the recommendation is to calculate the CHADS-VAS score and consider anticoagulation. So it's not a lot of AF, just 4 hours in 1 month.
And in terms of calculating the CHADS-VAS score, once they've had a stroke, their score's already 2, regardless. So you would think they're indicated. Now, in a young person, or even a not so young person where there's no clear cause of stroke, we often will do an echocardiogram and a transesophageal echocardiogram to assess the risk of embolic stroke. Now, this is a TOE where we put the tube in the esophagus, so the left atrium is closest to the screen. Can you see my cursor move at all? Or not really? Yeah.
Yes, David.
And this is the right atrium. This is the interatrial septum, primum, secundum septum, and you can see this very flappy interatrial septum, and there's a PFO, and you can see a colour jet going through here. So this is this 63-year-old woman who'd had a stroke, and she was referred for consideration of PFO closure. So what's the next step? A, surgical closure of the PFO. B, percutaneous closure of the PFO. Treatment with aspirin is as effective as PFO closure when PFO is likely the cause of paradoxical embolism. Or D, look for monitoring do prolonged monitoring to look for AF given a history of palpitations.
All right, so we've launched the poll. Answers are just coming through.
I might have skewed it by telling people that she'd been referred to me for a PFO closure. I'm not going to tell you yet if I close the PFO. What do you reckon? 10 more seconds?
Off you go, David.
Okay. So I'll get into the studies with PFO closure in a moment. And basically, if someone has had an embolic stroke from a PFO, there's data to close it in someone 60 years or less. And there's a benefit of that over aspirin. Firstly, she's older than 60, but I don't think that matters. It's not black and white. That's not actually the answer. If you can recall from the history, she actually had palpitations. And in someone like this who's got risk factors for AF anyway, like hypertension, diabetes, I think you do have to ask yourself, does this person have AF? So I might just get this off my screen, sorry. So she was, so this is another PFO. So not all PFOs are created equally. So you can see this is a hyperaneurysmal PFO, high risk situation. And I'll get to the question in a moment, but she actually had a loop recorder, not a loop recorder. She had one of these heart bugs, where you can monitor for 3 to 4 weeks, and she actually had AF. So the actual answer for that multi-choice question was monitor for AF for her. But closing a PFO is not a big deal, and I think the hardest decision is who to close. The actual procedure itself can be quite quick. So it's often an elastic metal called nitinol, which squeezes into a tube. You open up one side in the left atrium, the other side on the right atrium, and eventually it will seal. This is a procedure we just did the other week. When you have a stroke due to a PFO, it's actually really easy to cross the PFO. So this is from the inferior vena cava through the right atrium into the left upper pulmonary vein, the left atrium. We swap that over for a bigger tube. Then you open up one disc in the left atrium. Then you pull it back against the interatrial septum. So it's coming there. And once it's against the wall of the interatrial septum, it's relatively easy to open up the right atrial disc. You just desheath it. And it's just taking its time to get there. But basically, then you've got a PFO closure. Check with ultrasound or whatever means you want to check that it's closed, and then you release it and pull the tube out. And honestly, for the majority of these, it's a really quick, easy procedure, a day procedure under sedation that takes 20 minutes. In people with more complex anatomy, we often use transesophageal echocardiography or intracardiac echocardiography. So what's the, not going into this particular patient, but what's the data for PFO closure? So in 2017, there was these 3 large trials that were randomized control studies comparing people who'd had a clear embolic stroke with presumptively due to a PFO, and compared to that to mostly people with an antiplatelet regime, whether it be aspirin, clopidogrel, aspirin and pirsantin. And what they found is that there was a clear benefit of PFO closure over an antiplatelet regime. Between the 3 studies, the average was about a 4 to 5% risk of stroke at about 2 years if you just used antiplatelet agents, compared to PFO closure where the risk was 1 or 2%. In that PFO group, generally if they've had a stroke after a couple of years, it's usually due to a non-PFO related stroke. So these are the 3 big studies, but they basically use different devices and more or less said the same thing. And so this is one of the devices we use. So getting back to this woman who almost certainly we thought would close a PFO, she went on to have a heart bug monitor. Atrial fibrillation was detected. She was commenced on anticoagulation. And while the PFO, you might say, well, could that be the cause of stroke? She's going to be on lifelong anticoagulation anyway. And that's most likely the cause of stroke. And therefore, PFO closure is not indicated when someone's likely to need long-term anticoagulation anyway. I think there would be people who did close a PFO, but really when you look at guidelines, that's not proper management. Now, I'm going to stretch the truth a little bit now. This going 15 years on for this woman. She's now 78 years old. Her renal function's deteriorated. And this is like a real life situation. Her GFR's 20. She's now on warfarin. And she's having recurrent gastrointestinal bleeds. She's had numerous scopes. She's thought to have angiodysplasia. She's had treatment for that, and she's still having recurrent bleeds. So this is the last question. Which of the following would be considered? A, as no recurrent stroke after 15 years, you could stop warfarin. B, change back to a DOAC, such as low-dose dabigatran, as less bleeding risk. C, could now close the PFO to avoid use of an anticoagulant. Or D, consider device closure of the left atrial appendage.
So whilst those responses are coming through, David, just a question.
Yeah.
And I hope you know what he means by this, but the question is, why not do both?
Yeah, no, so I think that's a fair question. And I think some people would do that. I think when you look at risk scores for PFOs, you look at the anatomy of the PFO, and she did have a high risk PFO, but you got to recall she's lived to 63 and never had an event. Then she's had AF, which is so what's the relative risk of each of them to cause a stroke? Your relative risk of AF causing a stroke is about, for her, it's probably like 5 in 100 per year. The relative risk of a PFO causing a stroke is probably a few in 1,000 per year. So if you were to balance up that risk, it's clearly it's much more likely that the AF was the cause of her stroke. So that's the first point. I think then the second point is, do anticoagulants protect you as much from stroke in the setting of a PFO as closing a PFO? the studies on that aren't that clear. So all these randomized studies had a small subset of people on anticoagulation. Maybe there was a marginal benefit for PFO closure. So for her, you know, I think that's a fair question. And I think for someone this age, I think it's far more likely that the AF was a cause of stroke, and her risk of recurrent stroke from that PFO is pretty close to minimised by just being on anticoagulation as opposed to giving an anticoagulant. So I hope I've answered it. Now, if you asked another interventional cardiologist who closes PFOs, I think they'd probably be a bit trigger happy and close it, but I don't really think the data would support that at all. Now, this was a tricky question because her GFR was 20, and I guess I was trying to, I think firstly, as no recurrent stroke could stop warfarin, I think her risk of strokes gotten higher over the years because of her age. Would you change back to a DOAC as there's less bleeding risk? I think with a GFR of 20, she, you know, I know there's some recent studies saying maybe you could try them, but I think this is someone who would be really at high risk of bleeding with that dose of dabigatran, even in the absence of previous gastrointestinal bleeds, just given a GFR so low. Would you close the PFO? No, no, because for the same reasons as before, the AF was the likely cause of the stroke. So the answer is to consider left atrial appendage closure. Now, why do we close left atrial appendages in people with non-valvular AF, meaning people who have AF due to hypertension, diabetes, not due to like mitral stenosis? The majority, like nearly 100% of the causes of stroke relate to clots in the left atrial appendage. So it's not 100%, but pretty close. And you can see this TOE here. This is the left atrium, mitral valve, left ventricle. This is the left atrial appendage. You can see this little clot bouncing around there. So this is a high-risk situation. And in people like this, you would jump to starting anticoagulation and to reduce the risk of that embolizing down the left ventricle and into the aorta. So that's the rationale of doing a left atrial appendage closure. You would never close a left atrial appendage if you saw a clot like that in the left atrium, but I'm just giving you the rationale for closing it. Now, how do you close a left atrial appendage? It's one of the more complex left atrial interventions we do. So a PFO is really, really easy. The left atrial appendage is harder and has more risk. And, you know, I think the risks are about a 1% risk of death or stroke at the time of the procedure. How do we do it? We do it under transesophageal echo guidance. You do a transeptal puncture. In this lady, this is not this lady. If you've got a PFO, you may go straight across it. But in people who don't have a PFO, you would puncture the intraatrial septum like you would with a AF ablation. And then you cross the intraatrial septum with these large tubes. This is an angiogram of the left atrial appendage. And this was a big one. So this is one that was right on the borderline of being too large to close with an appendage device. There's a variety of devices. This one's the Amplatz device. So here it's a funny shaped thing, but you open up the ball and then you basically twist it in a way to block this hole, and you're basically trying to put a waist in here and an arm in here, and you'll see that in the next procedure. So this is a transesophageal echocardiogram here of the same patient. We've opened up the ball, and then this ball opens up into this like tire shape, and this is like a flap that I think in this procedure we pulled this up a little bit, and it basically closes off this left atrial appendage, and this will eventually clot off, but that will prevent clot entering the circulation. And these have, if you can close a left atrial appendage successfully, this provides as much benefit, if not more, than anticoagulation. And you generally keep people on dual antiplatelets for up to 6 weeks, and then maybe aspirin long term. In people with cerebral bleeds, you might not put them on anything. So just with a take-home slide at the end of the day, I think while the exciting things that I'm involved with are like PFO closure and closing left atrial appendages. I think you get more you get more benefit treating your lifestyle factors and your vascular risk factors, along with treating AF. You'll provide more benefit for future stroke risk reduction compared to any of the things that I generally do. So I think targeting an LDL between 1.8 to 2.6, I think we tend to be more aggressive now. A blood pressure below 140 on 90, getting people fit and trim, treat diabetes aggressively, using the proper antiplatelet regime, and in people with AF, then treating with a DOAC or warfarin if possible. So I'm going to stop there, and I'm happy to answer questions if we have time, or we can answer questions at the end.
Yeah, so if anyone has any questions, please pop them in the chat.
Yeah, I'll ask a question of David. Everyone else is being shy at the moment. So, David, if clearly this patient had paroxysmal atrial fibrillation, as in she wasn't in atrial fibrillation at the time immediately after the stroke. Was there any consideration, or do you think there's a role for curative treatment for AF? So that is ablation for AF to reduce not only the risk of stroke, but also the potential complications of anticoagulation?
Yeah, I reckon you can answer this one better, but I think when AF ablations were first done, it was always thought to be a potential that you could cure the AF and then you didn't have to worry about anticoagulation. But that seems to not be the case now. I think most people after AF ablations, unless they're young and have a low CHA2DS2-VASc score, would end up being on anticoagulation long term. And in this woman who's had a stroke, I think at this age, I think she's got enough vascular risk factors that you would think even if she did have an AF ablation, she'd still end up on long-term anticoagulation. I think we tend to be quite aggressive with intervention, but I think just simply treating with medications would provide her more benefit than intervention in her case. What do you think?
Yeah, I think you summarised it pretty well. If generally 3 to 6 months after AF ablation, if there is no recurrence, potentially you can stop anticoagulation in a patient who hasn't had a thromboembolic event. I think you'd be a lot more cautious in someone who had a previous stroke.
Yeah.
Okay, there's just one question that's come in that I might just ask David before you kick off, Gopal, or two now. How common is PFO?
Yeah, so there is about 20%. It depends on the type of study, whether it's a post-mortem study but not all of them are created equally. And if you saw that really flappy one, or, for this patient, she had a really flappy type of aneurysmal intraatrial septum, that's probably more like less than 2%. But your risk of stroke is not that high in those people. So there's a few guys in the world that close these prophylactically, and we all think they're a bit crazy. So there's a guy in Switzerland and a couple other guys around, but you generally don't close them prophylactically. So they're common, 20%, but the high risk ones are probably closer to a few percent.
Okay, great. And just one last one before we move on. What is the risk of stroke when switching to heparin?
So switching from dabigatran. Oh, is this you, Maggot? So what's the risk of stroke when switching to heparin? So if you're going from dabigatran to heparin, I wouldn't think there'd be much of a risk. What's the timing of that? So you generally don't treat with heparin up front when someone presents with stroke because of the risk of hemorrhagic transformation. In someone who's been on an anticoagulant and you just want to cover them for an operation, I think the risk is really low. So the typical situation is someone has AF, they're due to have an operation, you just generally stop because the studies have shown that doubling up or bridging with heparin has a higher risk of bleeding in that situation. I'm not sure if that answered your question.
All right, thanks, David. We might move on now to Gopal. Thank you for your time, David. Hang on, I'm sure Gopal's going to ask you more questions throughout his presentation. He's keeping you on your toes. So I'll hand over to you now, Gopal. Thanks.
Okay, thanks, Sandra. So for those who don't know me, my name's Gopal. Unfortunately, I'm not in a beautiful private clinic like David. I'm actually at the in my public hospital office, so the lighting's not quite as good, but I hope you can all still see me. People tell me that I'm younger and better looking than David, so maybe that might make up for it. So I'm going to talk to you just quickly about a new technology in pacing, and that's what we call a leadless pacemaker. I'll qualify it at the beginning just by saying that there's only one device that's approved in Australia by the Therapeutics Goods Association, and that's the device supplied by Medtronic in Australia. It's known as the Micra. This device is currently not on the private prosthesis list, and there is no MBS item number, but it is TGA approved, and if funding is available, can be used. So, what's happening? Okay. So just a bit of background to have a quick look at where we are in terms of pacing therapy. So if you follow both up and down, the earliest pacemaker was in the 1950s, and it was this externalized device, very crude device with wires running into the heart. Not long after that, in 1960, we had the first implantable pacemaker. And there's been a gradual evolution in pacemaker technology since then. Essentially, with better battery technology, the devices have become significantly smaller in size and offered greater functionality. In the late 1980s, we had the big change with the ability to pace and sense the atrium as well as the ventricles, so our dual chamber pacemakers. They then developed rate responsive function in the 90s, so these pacemakers could adapt the heart rate to a person's level of activity. And more recently, we've seen pacemakers that are MRI compatible, so patients with these devices can now enter an MRI scan. And they also have what we call remote monitoring, where they can send us information through a secondary device located in the patient's home, where we can often pick up a problem before a patient experiences a adverse clinical outcome. And just recently, in the last few years, has been the next sort of generational advance, and that's the leadless pacemaker. So it's taken almost 60, 70 years to get to this stage. But this concept was actually talked about very early on, as early as the 1970s. So the leadless pacemaker was first described in the Journal of Electrocardiology in 1970. And I'm not sure any of us would want this device because it was powered by atomic energy. But that was the only way that they could miniaturize a power source at that stage. Now, obviously, no one's going to want a nuclear-powered device in their chest unless they're Iron Man. But this particular device, this concept was introduced many years ago, and it took almost 50 years to be able to commercialize it and bring it to the market. So what are we talking about when we're talking about pacemakers? So generally our patients who require pacemakers have either symptomatic bradycardia, what we call sick sinus syndrome or sinus node disease. So these are patients who have alternating periods of atrial arrhythmias, atrial tachycardia or atrial fibrillation, followed by periods where they have slow sinus rate and sinus pauses. So this is basically the sinus node, the intrinsic pacemaker of the heart starting to fail, and when it fails, it either fires rapidly or beats very slowly. Then there are patients who get degeneration of the cardiac conduction system and develop complete heart block. So the way to think about that is, you know, we talk about the wiring system of the heart being prone to wear and tear, much like people, you know, get arthritis of the knee or the hip. And then there are some other causes of bradycardia as well, which require pacing. Now, in terms of our guideline therapy, where a leadless pacemaker fits in, generally sinus node dysfunction. So imagine if the sinus node is starting to fail and they're having sinus bradycardia, the treatment is actually atrial pacing. However, most of these people don't require pacing very often, and a ventricular pacemaker will actually stop these people from fainting and prevent symptoms. So a leadless pacemaker or a ventricular-only pacemaker can be used in patients with sinus node dysfunction. It can also be used in patients with AV node, either in situations where we don't think they're going to require much ventricular pacing, or the risk of putting in a second atrial lead is considered significantly high. So the Medtronic Micra, so the leadless pacemaker we currently have available, is intended for class 1 or class 2 indication for a single chamber ventricular pacemaker. So that's the important concept there, is this device is only a ventricular pacemaker. And the common indications are symptomatic paroxysmal or permanent high-grade AV block in the presence of atrial fibrillation. So we've been talking a lot about atrial fibrillation. If someone has atrial fibrillation with heart block, there is absolutely no need for an atrial lead, as they do not require any pacing or sensing of their atrium. Similarly, it can be used as an alternative to a dual chamber pacing when atrial lead placement is considered difficult or the patient is considered high risk. Now, there are some other considerations for why we would think about putting in a leadless pacemaker. Patients who've already had complications from a transvenous device, so patients who've had an infection, had a pocket erosion from their pacemaker, have required extraction. More commonly, you know, one of the things that we see very often these days is most of our patients are outliving their devices and leads. What I mean by that is that the leads are starting to fail during a patient's lifetime, and they're requiring either new leads or consideration of alternatives for pacemakers. Patients who are at significant infection risk. So the big problem with transvenous pacemakers is there is hardware, there's a prosthesis basically sitting within the circulation. So anytime someone gets a transient bacteremia or has an infection elsewhere in the body, there's a high risk of seeding a pacemaker or a pacemaker leads. There are sometimes anatomical or vascular issues which prevent us using traditional pacemakers, such as venous occlusion, either from multiple leads. I often see this in patients who've had cancer treatment, had VASCATs or vascular catheters, vascular ports, even PICC lines causing vascular occlusion, which is usually not clinically significant, but makes it very difficult to pass other hardware through the veins at a later stage, particularly if they need a pacemaker. People with congenital venous abnormalities are not that uncommon, and people who are high risk of pneumothorax. So to enter the venous system with a traditional pacemaker, we often have to either puncture the axillary or subclavian vein, and there is a risk of a pneumothorax, which can be potentially life-threatening in patients with severe lung pathologies. Other things in the elderly, you know, a pacemaker is a surgical procedure and does carry a risk. The sedation or anesthetic we use to implant a procedure also carries a significant risk. And then sometimes there are patient preferences, usually cosmetic or occupational. So people who have occupations or play sports with repetitive shoulder movements will often damage transvenous pacemakers. So we want to change from this lump in the top of the chest with a surgical scar to basically a minimally invasive procedure to deploy a pacemaker. The other problems, we've spoken about a few of these: infection, bleeding risk, erosion, and also failure. So this is one of our patients with an arrow sign pointing to a lead that is sitting between the clavicle and the first rib. And this is a segment of the vascular tree that is susceptible to motion and compression. And what's happened here is repetitive movements of the shoulder have actually caused the wires in the pacemaker lead to fracture and disconnect, and hence the patient's had a pacemaker failure. So let's talk about what the leadless pacemaker actually is. So this is a picture of a traditional pacemaker with the lead, and below it is what we call the leadless pacemaker. Now, obviously, this is a dramatic representation because the pacemaker is appearing much larger than it normally is. However, the leadless pacemaker, one of the advantages is it's significantly smaller in size, and it can be delivered completely percutaneously. So the way that this device is delivered, and I'll show some examples of it, is through the femoral vein. It's a catheter-based delivery system, and the device, which contains the lead, the battery, the microprocessor, the whole thing in that small device is essentially placed directly within the right ventricle. But we want to maintain, we don't want to take a step backwards in terms of the functionality of current pacemakers. So we want this device to be able to last a long time, patients still be able to have MRIs. We want rate adaptive pacing, so when the patient exercises, it will pick up their heart rate. And we want to be able to continue remote monitoring and so forth. So these are some pictures of the actual device. So it's about the size of a AAA battery, but a little bit thinner. This is the delivery catheter and the introducer sheath. This is a 27 French sheath, so that's about has a diameter of about 9 millimeters. So it's about the size of your finger that we're actually putting into the femoral vein to deploy the device. So the device is very small. It's 0.8 cc, has a length of 26 millimeters. Now, one of the interesting things is, although the device is basically a miniaturized pacemaker, because it's in direct contact with the heart muscle and doesn't need to transfer energy through a lead, the battery longevity is significantly enhanced. So much so that although it's a significantly smaller battery, it lasts as long as a traditional transvenous pacemaker. It has all the functionality. It has rate response. It's MRI compatible. It has multiple accelerometers, etc. So you can see, again, this is a more realistic sort of comparison of the size difference. But you can see it has all the functionality and the longevity of a current transvenous pacing system. Okay, so the way we fix this device within the heart is by these, what we call nitinol tines, which are basically like a little flexible scaffold that grabs onto the trabeculation within the cavity of the right ventricle. I won't go into too much detail, but this is basically the delivery system. So there's an outer sheath. This is the 27 French sheath, which is inserted into the femoral vein. And this is the actual delivery catheter. So you can actually see on the end of this is the micro device. And this tool, this catheter, allows us to position and deploy it in the right ventricle. So what happens when we unsheath the device is the tines open up. So if you look here, the device is actually within the delivery catheter and the tines are basically folded up. As the delivery sheath is withdrawn, the tines open up and grip onto the trabeculation into the right ventricle. So the apical section of the right ventricle is very trabeculated, has lots of crypts and crevices where these tines grip and basically hold the device in place. Now, we have the ability of testing that it has actually gripped before we disconnect and fully deploy the device. This is some of the histology that also shows why this device works quite well and has a very low pacing threshold, because of the tines are non-reactive and basically gripping trabeculated muscle rather than going into the muscle as a traditional active pacemaker lead does with a screw which is inserted into the muscle. There is no fibrous, this blue stuff is basically fibrous tissue around a traditional pacing lead. You don't get that with the micro, with the tines, and hence the threshold, that is the amount of energy required to stimulate the heart, remains fairly consistent over time. And this effect of fibrosis doesn't affect the battery longevity. Again, I won't go into too much detail on this, but these devices have multiple accelerometers. So accelerometers are what you'll find on your phones or on the smartwatches, which monitor heart rate and so forth. And basically what it can do is detect when a person is exercising and adjust the heart rate. These devices also have what we call a capture management. That is, they can ensure that only the minimum amount of energy is required to stimulate the heart, and so you don't unnecessarily deplete the battery over time. I'll go on a little bit further in the interest of time. So one of the things a lot of people ask me is, well, how do we implant this device? So I'll go through some of the steps. The first thing is it is considered a minimally invasive procedure. So although we use a 27 French sheath, we can close this up at the time of the procedure, at the end of the procedure, and theoretically patients can actually go home the same day. This is an example. I might switch and actually see if I can show you a video. Let me see if I can bring that up.
So we've got a couple of questions here too, Gopal, that we might ask along the way.
Yeah, why don't you ask that while...
So one of the questions is, how long does the battery last? When would you need to replace the battery? And what happens if the micro gets dislodged?
Okay, so the battery lasts approximately 12 years. Now, there is the ability to capture or retrieve the device in the acute phase, and what I mean by that is probably within the first 1 to 2 years after implant. Beyond that, the device sort of becomes encapsulated, or basically that you develop scar tissue within the heart, and it becomes part of the heart muscle and cannot be retrieved percutaneously. Then the only way to retrieve it is actually with open heart surgery. Having said that, it is theoretically possible to deploy up to 3 micras in a single ventricle. So if a patient has a device that is approaching end of life, the next step would be to insert a second micra in a different location within the right ventricle. And because these devices are relatively small, the bulk of the devices does not have any effect on cardiac function. And as I said, that can be done up to 3 times. So potentially with the micro technology, you could get up to 36 years of leadless pacemaker life. So again, you know, you'd have to think very hard about doing this in much younger patients. However, in 36 years, who knows where the technology will be. You know, people are already working on what they call biological pacemakers. So that is using stem cell technology and other constructs to create actually biological pacemakers rather than electrical and mechanical pacemakers. Sorry, the second question, I think I've answered both, wasn't it? It was longevity and how to retrieve the device. So
there was just another additional question. Would you replace the battery when it gets low?
Yeah, so any pacemaker, and particularly this device, we can't actually replace the battery itself. We actually have to replace the whole device. So when patients with a transvenous pacemaker or defibrillator, when the battery runs low, we actually have to operate, disconnect the leads, from the device, take the device out, put a new device in. And it's similar for the micro. It doesn't have a removable battery. Now, it's beyond the scope of this talk, but there are some newer technologies using acoustic energy to power pacemakers. So that's, you have an additional device on in the subcutaneous tissue on the chest wall that emits an acoustic energy that can basically stimulate a button-like pacemaker within the heart. Okay, let's see. I might show you a quick video. The first step is obviously gaining access for the micro. I'll let them walk through.
Are you just breaking up a bit there, Gopal?
This is usually done under ultrasound guidance.
Gopal, you might have
I
to
might just mute it. Can you hear me now?
Yeah, that's better.
but you might have to stop.
Okay. So, look, just talking you through it. So usually we access the femoral vein under ultrasound guidance, and then we use a small sheath to confirm the position using fluoroscopy. And then once we enter the vein, we can then advance the outer sheath. So you can see it's a 23 French sheath going up the femoral vein, up the IVC, and into the right atrium. It is a big sheath.
Gopal, I'm not sure if you've got to stop share and then start share again with your video.
All right, you couldn't see that?
We just have a still screen there. So
All right,
you might have to
okay.
stop share and start sharing.
Just talking to myself. Okay. All right. Yeah, let me see if I can try that again. So hopefully you can see that now. So this is an example of femoral vascular access, and we use a small sheath initially to enter the vein, and then we have to enlarge this opening to get this 10 millimeter diameter large sheath into the femoral vein. So we use dilators basically to make the tract a little bit larger, so progressively larger dilators, and then eventually we put in the large sheath. So you can see, you know, it's a fairly large sheath. We watch under fluoroscopy and advance it up into the right atrium through the IVC over a wire. Just bring up another video here.
So whilst you're bringing up the video, there's a couple of questions. Does it increase
sure.
the risk of pulmonary embolism?
That's a great question. We usually use a degree of, when I say a degree, we use a therapeutic dose of heparin during the procedure. As the device is sitting in the right ventricle and it's a high flow contractile environment, the risk of forming a thrombus within the ventricle is virtually minimal. So patients don't need antiplatelet agents or anticoagulants with this device in the ventricle.
Great, thank you.
Okay, I'll just show a quick video of how we deploy the device. So through that large outer sheath, we then pass the delivery catheter. And you'll then see the fluoroscopy. So this is the tool, the handle we use to control the deployment device. And essentially, we pass this catheter across the tricuspid valve. So if you imagine this is the tricuspid valve here, this is the right ventricle. We're aiming for the apical septum of the right ventricle where we position and deploy the device. Now this can be done as quickly as 10 to 15 minutes. The average worldwide, the average duration to do one of these cases has dropped down to about 22 minutes on skin to skin in one of our large registries that we participate in. Let me just bring back up the slides.
So as you're doing that, just another question, can it be done through the arterial, the radial artery?
So we're trying to deploy this device in the right ventricle, so in through the venous system. So firstly, we can't deliver it through the arterial system. We can't really use the veins in the upper limbs. Essentially, they're just too small to advance such large hardware through to reach the heart.
Okay, thanks. All right, just got a few more minutes, Gopal. So
Okay. Sorry, my slides seems to be frozen. Okay, I will just maybe skip ahead a little bit. So someone was asking before about what to do when the battery runs flat. This is from an animal model where the battery hadn't run flat, but to prove that we could deploy more than one device and also have no impact on the hemodynamics, multiple devices were deployed. Okay, just briefly, some of the evidence. Look, there's been a huge number of these devices put in worldwide. The big study from 2015 is what we call the IDE study. So for those who are not familiar with IDE studies, these are basically FDA, so in the US, regulatory mandated studies before a device can be brought into the US market. And basically, to summarize, the success rate of putting in this device is very high, comparable to a transvenous pacemaker. It works over the long term, and the complication rate is very low. In fact, if we look at the complication rate overall, it actually seems to be significantly lower than a traditional transvenous pacemaker. So I might stop there and see if there are any more questions.
okay, so there's just looking through. There was a question earlier on, but it was about Dr. Khoury wanted some detail on implementing a regular pacemaker. I'm not quite sure if you want to just do a quick overview on
Sorry.
that. Implanting a regular pacemaker.
Okay, do you mean the procedural steps?
Yeah, he just said he wanted some detail, Gopal, so you'll have to give him some detail.
Look, generally, as with any procedure, we do it with sedation or with an anesthetic. We can do it just with local anesthesia as well. The traditional implant site is the left pectoral region. The device usually sits in the subcutaneous tissue, so just above the pectoralis major. And the leads are implanted through the venous system by either puncturing the axillary or subclavian vein, or sometimes we do, or more often we do a direct cephalic vein cut down and introduce the lead directly through the vein. Most pacing leads that you'll come across these days are active, so they have a small screw on the end, which we attach and fixate to the inside of the myocardium. Look, a pacemaker is a very, very simple procedure. It takes about 30 to 40 minutes. We can actually do same-day discharge. Often, though, patients will remain in hospital overnight. We can do pacemakers with patients fully anticoagulated. So as opposed to many other surgical procedures, we do not need to stop anticoagulants, be it warfarin or any of the novel anticoagulants. I hope that answers that question.
We hope you have enjoyed this GP education session. If you wish to gain CPD points, this activity is now a quick log activity, which means you need to head to the Royal Australian College of General Practitioners website to log your own points. We hope you can join us for more of our GP education in the coming weeks. Thank you.